Right, so today, someone by popular demand we wanted to know about allergies, and we wanted to know about allergies for years, actually. And I don't know a lot about them, other than we don't know sort of answers. So, we have an UHSM consultant allergist. Mm-hmm. Is that correct?
It is correct, yes.
Who's Susanna, who's going to come and talk to us about the original title was about a specific, what Professor Denning was calling an allergy, but I believe it's not actually an allergy. So Susanna's going to tell us all about that now. So over to you, Susanna. I'll have to sit behind you, unfortunately.
That's okay.
Right, over to you.
Well, so welcome. I'm very pleased to be here. I hope I can give you a little bit of information if it was indeed by popular demand that you wanted to know more about this. It is, I have to say, a very complex topic, because everything is really an allergy. I'm not starting well, but I've tried to break it down for you in a way that is understandable, and I'll hopefully be able to answer some questions you may have as to why people react to aspirin and related drugs. What exactly is it, and how do we manage them? What can we do about it? Which I presume are the answers, and then also cover the issue of salicylates in diet, which is a sticking point and a controversial one, but I'll try and cover as well. If you have any questions and you'd like to interrupt me, feel free. Otherwise, we can always discuss things in the end, but it's up to you. So, this was working before. We're starting well. Right. No. Oh, you are, aren't you? We just tested it. Right, I'll just have to use. Yeah, we will. Okay. Now I think that this froze because it does have a.
Oh, because I was messing with the slide. My fault. I do apologize.
It's okay. So how?
So now it should work with the space bar.
Okay. Space bar. So there's no point in trying this. Oh, it does work. Okay, yes. Perfect. So, as I said, I tried to break it down, and what I'm going to do is talk about, firstly, briefly, what exactly are adverse reactions to drugs and what are the main types and how we distinguish them. It stopped working again. There we are. What is an allergy again? How does it work? How we develop the symptoms that you normally relate to allergies. Talk a bit about aspirin and NSAIDs, which I think is a very interesting topic for a number of reasons. Reactions to NSAIDs, so non-steroidal anti-inflammatory drugs. How we manage them, aspirin desensitization in particular. And then a little bit about salicylates in foods, and questions at the end or at any point if you want to. So, reactions to drugs. You have a question?
Can you speak up a little bit?
Oh, okay.
I'm hearing it tuned in, but it's still a bit low.
That's okay. Do my best. Is this better?
Yeah.
Okay. So, reactions to drugs, how we sort of classify them. We have two main types, really. The effects, you've all heard about gastrointestinal bleeding with aspirin, for instance. That is one of the examples. Or toxicity, when you take, for whatever reason, more than the recommended dose, and there will be consequences of that. So these are predictable. We know exactly that they're going to happen with which dose, and they're the most common. They have nothing to do with allergies, as you can imagine. But then you have the less common type, type B, which affects only susceptible individuals, whereas anyone who takes more than they should will have toxicity. This is only some people. For some reason, some of them we know why, for some of them we don't. They are very uncommon, unpredictable. They generally are not dose dependent, so sometimes even low doses can lead to reactions. And that's what we call drug hypersensitivity. So really, hypersensitivity, and this could be drug, but could be food as well, could be caused by what we call immune mechanisms, which is what we say is allergic, and I'll show you that in a minute. Within that group, they can be caused by IgEs, which are the allergy antibodies, and they're the most common type of immediate allergic reactions, or could have other explanations, which I'm not going to cover today. Or they can actually have nothing to do with the immune system. Exercise, changes in temperature are examples. There's a number of other factors, but they will actually present in exactly the same way, which is why they're called pseudo-allergic, which is basically a term meaning they mimic allergy. They look like an allergy, but there isn't really allergy antibodies or anything related or specific to the culprit. I hope that makes sense. So what is an allergy? Allergies are basically an abnormal response of our immune system to something that should be harmless or tolerated. So examples you can see here, and that something is what we call an allergen. So you can see here that generally we're all exposed to animals, to pollen, to dust, to drugs, which is what we're talking about today. Generally, they're not exactly good for you, but they shouldn't do you any harm. They shouldn't cause any harm. And for most people, they don't. Everybody enjoys the summer when the pollen counts are high, and people who don't suffer with hay fever are absolutely brilliant. But there are those who, for some reason, if they're exposed to pollen, they will develop significant symptoms. And why does that happen? And that is one of the questions that Graham was actually asking me earlier. We don't quite know why people develop allergies, but we understand that in some people, exposure to some of these substances, these are just some examples, will lead to their immune system behaving or treating those substances as harmful, whereas they're not, and therefore mounting a response towards them. So this is what we call, in a very simplistic way, sensitization. So you become sensitized to those substances. You develop the allergy antibodies, the IgEs that I talked about, to those substances. And therefore, the next time you're exposed, you'll have a problem. So it works. They happen, or the symptoms develop shortly after exposure. So the hay fever, which is actually more correctly called rhinitis, because it's not just hay and there's no fever involved, but nevertheless, it's what people tend to sort of call it. It can also happen outside of the summer because of exposure to dust mites, and that is also the similar sort of problem with a different allergen. Most food reactions, so allergic reactions to foods, are also falling in this group. Asthma related to allergies and drug reactions that we're talking about today. You then have the other group, the delayed ones, and there's a bit of an overlap between this. Our immune system is not compartmentalized in a way that things are completely separate, but the eczema, the atopic eczema that generally is a problem in children and kids, but some adults can continue to have it throughout their life, is generally a delayed reaction. So different, it's not allergy antibodies, it's a different type of cells, but there is sometimes acute flare-ups when the patients are exposed to a food, for instance, or to an allergen, and inhaled allergens like dust mites. You have contact dermatitis. This is one of the most common with nickel, for instance, but it can happen with fragrances, with a number of other substances. Topical drugs even. Interestingly, topical antihistamines are one of the most frequent drug causes of contact dermatitis. So if you need antihistamines, take them by mouth. Some food reactions can be delayed, even though the majority are really immediate. And the delayed ones tend to be mostly gastrointestinal problems, very unusual. And several drug reactions are delayed as well. So the drugs can really cause a multitude of problems. The culprit in the immediate reactions is this little cell here that we call the mast cell. And this will all fall into place, hopefully, because you might be wondering, why am I seeing this? So this sort of black thing with blobs there. So these cells are scattered all over your body. They are on your skin mostly. They're also on your gut, on your lungs, on your heart. And they produce these granules with lots of substances inside. And those substances are mostly histamine. So that's one of the main mediators of the reactions and the symptoms you see. But there's a lot more, all pro-inflammatory. And what happens is when they're activated, and I'll show you how that happens, they release the contents of these granules and look a little bit deflated afterwards and lead to a number of problems. So this is your mast cell with the little granules inside, and these are the Ig antibodies that I told you about. So you've already been exposed to, let's say, a penicillin, and you developed IgEs that recognize the penicillin. You become sensitized. If you take penicillin, it will be recognized by those antibodies, will then send a signal to the cell to say, you need to activate and do something. So the cell then releases the contents of the granules, and this leads to the symptoms of allergic reactions that you have, if that makes sense. So you will have the hives, a very common one. You will have swelling, specific type of swelling, not the swelling that happens when you have fluid retention in your feet, but something like this, generally actually affecting the head and the face, lips mostly. Itching, very, very significant. In fact, it comes with the urticaria as well. Hay fever type of symptoms, sneezing, runny nose and eyes, wheeze, cough, breathlessness, so an asthma attack, vomiting, diarrhea as well, gastrointestinal symptoms, And you could also have a drop in blood pressure, which makes you feel dizzy. You may even lose consciousness. And generally, all of these combined constitute what we call a severe allergic reaction or anaphylaxis, which you might have heard of. So I hope that allergies made sense, and it will link it to the reactions to NSAIDs in a little bit. So NSAIDs. NSAIDs stand for non-steroidal anti-inflammatory drugs, because the other group of anti-inflammatory drugs we have are precisely corticosteroids. So this is the non-steroidal alternative, which is why they have that name. And aspirin is a really interesting drug, as I'm sure you're aware. So just to give you a little bit of an overview, the first description of use of related substance, so aspirin is a synthetic drug, but was discovered in the bark of the willow tree, and it's also present in other, particularly the meadowsweet grass and other plants. So the first records of using willow for medicinal purposes are actually in the Ebers Papyri, which were medical texts that showed that the Egyptians and the Sumerians as well used it to control pain and inflammation. And then Hippocrates, who is considered the father of modern medicine, also used willow leaf tree to help with childbirth pain in women. So that's also been described, and that was about 400 BC. So you can see how far back this goes. But it was only obviously moving fastly forward. It was only recently that we actually were able, it was Joseph Buchner who was able to isolate the actual substance in the willow bark and tree and leaves that was responsible for these effects of controlling pain and fever, which he called salicin. And the reason why he did that is because the scientific name for the willow tree is Salix alba, so salicin from salix. This wasn't really very stable and not particularly tasty, in fact very sour substance, and it was in 1897 that a chemist working for Bayer, a pharmaceutical company I'm sure you all know about, who patented aspirin in 89, he decided to join an acetyl group to the salicin, and that's what made aspirin acetyl salicylic acid. And then Bayer called it aspirin and patented it in 1899. Interestingly, they actually, the name aspirin is derived from A from acetyl, spy from spirula, which is actually the name of the meadowsweet, so they went for that instead of the willow. And then in, which was, I think, something that was used in drugs at the time. Since then, aspirin has been used significantly. Lots of other drugs have been developed and have become available that have similar anti-inflammatory properties. But the interesting thing about aspirin is that it seems to do a lot more than that. And it's probably not aspirin, it's the salicylic acid, as I will tell you in a little bit. And so, as you all know, aspirin is now being used because it has significant benefits in terms of cardiovascular prophylaxis, or prevention of cardiac risk, heart attack, stroke, etc. And so there's been a number of studies showing that. And recently, also studies showing that it may have, or it does have actually, this is a result of a meta-analysis which basically looks at several different studies and pulls them all together, and found that actually prevents the risk of bowel cancer and esophageal cancer. And so basically gut cancer seems to be prevented by regular intake of aspirin as well. So there's a number of things that it does. And there's other studies. There's studies that we're waiting for results next year that will hopefully give us even more benefits in different users. But as I said, aspirin is one of the non-steroidal anti-inflammatory drugs, probably the first one to become available, which is that one, and it's part of this group. But it's now become a very big group, as you can see here. And I've just sort of separated them for you because what I wanted to show with this is, first, the number of drugs available. They all are classed under that umbrella because they all work in the same way. But they are chemically, structurally, completely different. So each one of them within this group, or that's on its own, the paracetamol, but all of these share structural similarities, but not between them. They have nothing in common. So already this tells you that if you have an allergy, or if you are reacting to, let's say, aspirin and ibuprofen, it can't be an allergy, because The allergy, the IgE antibodies recognize a specific thing of the drug, a specific part of the drug. They have nothing in common, yet you react to both. This is why I wanted to show you that before to see if that makes sense. So it isn't an allergy, but I'll tell you what it is in a minute.
Two allergies.
That is not impossible, very uncommon.
Very unlikely.
You could, and with foods that does happen. You can be allergic to milk and egg, for instance, which are completely unrelated. With drugs, yes, you can be allergic to more than one different drug, but generally that's not the case, no, and certainly not for NSAIDs, we know. So they are, as you know, widely used drugs. They're widely available over the counter. Not all of those that I've shown you there. So many are actually, some of them aren't even available in the UK, and most are only available on prescription. But several of them are available over the counter, and are used for these three main objectives: to relieve pain, to control inflammation, and to reduce temperature. Though aspirin, as we just said, has additional effects that the other ones do not share, for the different reason that it's the salicylic acid. So, as I said, diverse group, but what they do have in common is their mechanism of action. So the way they actually have those properties of reducing pain, inflammation, and fever is by inhibiting an enzyme that we have called COX, or cyclooxygenase. And just briefly, what this enzyme does is there are two subtypes, isoforms as we call it. One that we call COX-1, which is in every part of our body, and it has a significant role because it breaks down a lipid that we have also in our cells into these substances called prostaglandins, which have homeostatic effects. So that means they contribute to the normal functioning of our body systems. So they help in terms of renal functioning, protecting the stomach mucosa, so the lining of the stomach, and they help with platelet function. So they are really important, and this enzyme is really important for that reason, because it creates those substances. However, the other counterpart is inducible. So whereas this exists all the time, this one is only triggered to become active, I'll put it that way, by triggers, by stimuli, which are inflammatory triggers. So if you have an infection, very most likely example, there's a number of factors that will lead our cells and our body to produce that one, and that will also create prostaglandins, but in this case they will lead to inflammation. So I hope that makes you understand that what we don't really want to inhibit this one, we actually want to inhibit that one if we want to control inflammation. However, NSAIDs don't quite behave in that way. So aspirin, I hope you can see here. So this chart here basically shows how selective they are for the COX-2, which is the one that is related to inflammation that we want to inhibit. And most of the NSAIDs we use actually are much more likely to inhibit COX-1 than the 2. But they do. The way they inhibit COX-2 is that they need much higher doses, and they will inhibit COX-1 a lot more. However, since then, lots of other NSAIDs have been developed that have become much more selective for the ones that we really want to inhibit. So as I said, you've got the ones that preferentially inhibit COX-1, which also control inflammation because they do both, but we prefer not to use, and aspirin is there. Some that it's really halfway, and then some that are preferential. And within those, there are some that we call selective. They don't seem to inhibit COX-1 at all, which are called the COXIBs, precisely for that reason, COXIBs. And an example, or three rather, that we have in the UK are Celebrex, Celecoxib, Etoricoxib, and Paricoxib, so which are there. So now I hope that this sort of sets the stage for the reactions and the types of reactions that we have to these drugs and what happens. So 5 different groups, and I have to say things have evolved. When I started training to become an allergist, it was nothing like this, and I saw patients, they didn't fit into any of the categories, and I struggled to understand exactly what their problem was. But since then things have come a long way. I sound very old, but it's been more than 10 years ago, and so things have come a long way, and I am actually not very young, but there we are, moving on. And so we now actually have these 5 sort of groups of reactions which I think describe what might happen really, really well. So the first, the top 3 in sort of greenish color are the ones that are not allergic. They're the most common type of reactions to these drugs, and they have exactly to do with inhibition of COX-1. So when they inhibit this enzyme, and you may ask, well, everybody takes these drugs, and most patients will be fine with them, and that's true. This is why it's one of those type B reactions. We don't quite know why, but in some patients, them behaving in this way leads to these kind of effects. They don't have an allergy to them, nevertheless. But yes, there is a possibility you may be allergic, you may have allergy antibodies, which is the bottom two groups. So when it's really caused by a single NSAID, and it can either be immediate or delayed, but I'll go through each of them. So the first, these patients already have a respiratory disease. They will have it whether they take NSAIDs or not. They have asthma, they have rhinosinusitis, and they have nasal polyps. And this is a problem, and it will progress, and the polyps will progress and keep growing back when they're excised, even if they don't take any NSAIDs. However, if they do, they will develop symptoms. They may already have them, but it will be very clear that they take an aspirin, and within minutes, generally to a few hours at the most, but generally it doesn't take that long, they'll become breathless, they'll have an asthma attack, they'll have nasal, ocular symptoms as a result. So this is very clear that it's got to do with intake of that drug. But this happens whichever NSAID they take. So it can be aspirin, it can be ibuprofen. These patients will react to any of them, not an allergy. And this is, as I said, the most common. It doesn't happen in everyone. So within patients with asthma, about up to 20% will have breathlessness and asthma attacks caused by NSAIDs. So one misconception is still, I think, less and less we're seeing this, but patients with asthma are advised you cannot take NSAIDs. That's not true, because if you can think about it, 80% of the patients with asthma will be fine with them, and you're depriving patients of drugs that are potentially going to be very useful. In fact, they're probably at the top in terms of numbers of drugs to use. And in fact, yes, I didn't point that out, but in the aspirin timeline, I think it went into the Guinness Book of Records in 1970 or around about that, for being the drug that's mostly used. So they are very, very used, and they are important, they are required. So the fact that 20% of patients with asthma may have problems with NSAIDs is not a reason to tell every patient with asthma not to take them. But if they do and develop symptoms, then we know they can't have them and they can manage them, but not as a blanket advice without any history of problems, if that makes sense.
So that this reaction can't be managed. You just have to avoid aspirin.
Well, if the reaction occurs, it's managed as you manage an asthma attack and treat nasal symptoms. But you have to avoid all the NSAIDs, not just aspirin. You have to avoid all NSAIDs, because if you take ibuprofen, you'll have the same thing. If you take diclofenac, it's okay. If you take diclofenac, you'll have the same thing.
Yes. So
you have to avoid all NSAIDs, but there are alternatives.
If it was a true allergy, you could have a go at the allergy with an antihistamine or something like that.
You would still give them antihistamines, but the management, this is why I was trying to explain that pseudo-allergic reactions, which is what this is, they're exactly the same. Management will actually be the same, but the cause is different.
So there's still a histidine cascade in both?
Yes, in this particular case, there's a number of theories why this happens, but again, because of the so basically what happens when COX-1 is inhibited, or another enzyme that also, this is what I didn't want to get into because it gets a bit more complicated.
Maybe you shouldn't.
So it sort of deviates the pathway into different substances, which will then lead to these effects. So it's not so much histamine mediated. We do, I mean, if I have a patient like this, I might try antihistamines, but what really they need is a bronchodilator, a nasal decongestant, probably some eye drops. Antihistamines aren't really going to make that much of a difference here.
Okay. I'm just trying to get to the end point of the patient.
Yes, no, absolutely. As I said, I don't mind answering questions as I go. I think sometimes it's easy because otherwise everything gets bundled up at the end. So I was just going to say, in terms of prevalence, in patients who have both asthma and sinusitis with polyps, the number who will, or the proportion who will have problems with NSAIDs is much higher, is up to 40%. Again, not a reason not to take them, but it's something that if I see a patient who has asthma and nasal polyps, the first question I ask is, do you have problems with NSAIDs? Have you had reactions? And again, there's a 40% chance that they will say yes, if that makes sense.
I think Professor Denning needs to come and listen to this as well, because he referred to aspirin as an allergy and it clearly isn't.
No.
But for quite subtle reasons.
Yes.
Yeah.
So the other group, which is rashes, this is caused by that mast cell I've mentioned to you before, basically deciding to release the contents of the granules without any trigger. So the condition is because those cells are hyperexcitable, they're jittery, and they just misbehave in a simplistic way, which is very difficult to understand because it looks just like an allergy. And you can understand why it does, because the end result is the same. The mast cell degranulates just like when there is an allergy. The thing is, there wasn't one to begin with. Is that making sense? So these patients have spontaneous urticaria. But in this particular group, and it happens, so in patients with CSU, up to a third, if they take any NSAID, they will develop urticaria and angioedema. They may already have it, it will be worse, or if they're actually on the one day that they don't have anything, if they take the aspirin, the ibuprofen, the diclofenac, it will cause a rash or a swelling or both. So they will have it regardless, but can be triggered by NSAIDs. Just like the ones with asthma and the polyps will progress, the asthma is still a problem, but they will have symptoms triggered by NSAIDs. Then the third, no underlying condition like this happy group here, no problem. But again, when they take any NSAID, they develop rashes, urticaria, and angioedema. They won't have it otherwise. So this is just caused by taking these drugs. This is when, again, patients who don't have any underlying problem, and they will take a specific one, so let's say, for instance, ibuprofen, and they will develop urticaria or swelling or anaphylaxis even. So this will be, for instance, and it has been described for very few, it's a very rare occurrence, diclofenac, pyrazolones, which you don't use very much here, but diclofenac is one example. And so patients will only react to diclofenac, will be absolutely fine with aspirin, with ibuprofen, with everything else. It's only the diclofenac that's a problem because it's an allergy. I hope that's making sense. But the reactions, as you can see, are the same. We don't really know unless we take a history. Sometimes patients only took diclofenac and we don't know whether they have problems with the other ones or not. So the diagnosis isn't the most straightforward, but I'll get to that. But the main thing is that if we want to clarify it, we need to then try and see what happens with the other drugs from a different group. So they will have problems with a specific one or related. So within the same group, if you remember the groups I've shown you earlier, you had the diclofenac was within a group that we call the acetic acid derivatives. So all of those are similar chemically. So if you have a problem to a specific one, to diclofenac, you'll have a problem with the related ones, but not the ones from the different groups. Okay? And lung condition, but a specific NSAIDs or NSAIDs from the same chemical group can lead with a delayed onset. Everything else was very quick. This is more than 24 hours, sometimes days, a number of different conditions. This is a very severe skin condition with detachment, as you can see there, called Stevens-Johnson syndrome, and 10, which stands for toxic epidermal necrolysis, which is a very rare, fortunately very rare occurrence because it is a very severe one with mortality up to 30%. This is an interesting one, fixed drug eruption, and it's actually common, relatively, and it's called like that because patients will develop, this is a hand, and it tends to affect the extremities, so hands, feet, genitalia, and face. And patients will develop a lesion, sort of tends to be like a hyperpigmented, so a darker spot that can then develop a blister when they take a drug. And non-steroidal anti-inflammatory drugs are one of the common causes. There are antibiotics which also are associated with this kind of reaction, and a few other possible culprits. But the interesting thing is that it always happens in the same place. So you take, let's say, for instance, diclofenac, several days generally, could be a day later, and sometimes just 8 or 12 hours, but doesn't take that little normally, you'll develop that kind of lesion. If you stop taking the drug, that will eventually resolve. It will leave a dark spot that sometimes doesn't completely disappear. If you take diclofenac again, the spot will appear in exactly the same place. So this is why it's called fixed drug eruption, because it's the same place. The only problem with this is that you may have new spots coming. So when you take it again, so let's say you had it on your hand, the next time it will be on your hand, but it could be on your face as well, and the next time will be hand, face, and could be somewhere else as well. So it's not just one place. But some patients are lucky enough that it's always the hand, nowhere else, and so it's very easy in a way to diagnose. unless they're taking 3 or 4 different drugs, that could be the cause. And that's the problem with delayed reactions, because it can take days, and if you take several of them, all of them, any of them could be the culprit, and it's difficult to tease out, but there are ways around it. There are the much less common problems called something that is like a pneumonitis, so a problem with the lungs, but not caused by an infection. So it's a hypersensitivity and also affecting the kidneys. And another one I didn't put there that is also very common, what we call a maculopapular rash, so a measles type of rash, which is really red, itchy, smallish spots. Generally affecting mostly the trunk, not so much the arms or the face. So typical, like a measles rash, but one of the most common delayed reactions, and NSAIDs can cause that too. So those are sort of the most important thing. Really need to tease this out. I'll be probably not going into that detail, but you still need to make sure that you understand exactly what the symptoms were, how long after taking the drug, what happens with different groups, and try and work out what your working diagnosis might be. If you need to clarify, if a patient tells you already, this happens every time I take aspirin and ibuprofen, you already know it's one of the cross-reacting ones. And if it's a patient with asthma and nasal polyps, it just makes perfect sense. But if it's a patient who says, no, it only happened once when I took ibuprofen, I normally don't take aspirin or anything else, I have no idea, you don't know. And the only way to find out is to actually give them aspirin and see, which takes a risk, because if we're thinking of probabilities, they're very likely to react to aspirin as well. And you are potentially triggering a reaction that can be severe. Obviously, when we do provocative-intestinal allergy, we don't give the drugs in the therapeutic dose that you would take if you were taking them because you needed them to control fever or pain. We do it in a graded way, precisely to introduce some safety. So we start with small doses and build it up gradually in the hope that if there is a problem, with a lower dose it will be milder, we'll be able to see it, stop and address it without it progressing to anything more severe. But it still is a risk, because with allergies especially, or even pseudo-allergies, as is the case, sometimes even small doses can lead to severe reactions. So you are putting patients at risk. So sometimes we take the pragmatic approach of identifying alternatives and advising what needs to be avoided. But there are occasions when we feel this looks very much like a specific allergy. It's rare. I'll test for a non-related one, and if that's negative, then you confirm it. Importantly, no skin or blood tests available. So all we have really is the history and drug tests. As you can see, not ideal, but that's how it is. So management. As I said, depending on the type of reaction, which we get an idea from taking the history, we advise avoidance of all if it's the most common group where all of them react or cause reactions, or specific if it's otherwise. Important to have medical alert information, because again, these drugs are very commonly used. They're likely to be used in a scenario where you're not able to let people looking after you that you've got a problem with them, so this is important to carry. But also, it's not really good enough to say, oh, just avoid all NSAIDs, and if you have pain and fever, just deal with it. That's not really appropriate, I think. So we do try and find alternatives. And generally, in patients who react to all NSAIDs, paracetamol, which is a weak COX-1 inhibitor, tends to be tolerated. So that's an option, but it really only works for fever and mild pain. So really stronger pain, it doesn't quite cut it. And so we also try to find another option that, and it also doesn't have really much anti-inflammatory action. So it's mostly pain and fever, really. So we then try to find options that cover the anti-inflammatory and more stronger analgesic areas. And so the preferential or the selective COX-2 inhibitors that I've mentioned to you before tend to be tolerated in these patients, but we confirm that safely doing a challenge. So instead of doing a challenge to confirm there's a problem, we do a challenge to confirm there is not a problem. And then we give patients a card that tells them what they need to avoid and what are the safe alternatives. So they can carry that and show to everyone. So they know, and they'll be safe. There's no reason in these cases to give them adrenaline auto-injectors, which is a question we get quite a lot, because they're meant to be used for cases where accidental exposures are not preventable. So food, insect stings are the first ones that come to mind. Drugs, you can't say that. If you know exactly what you're allergic or pseudo-allergic to, what you react to, if you've got it written down, if you show it to everyone, and if you've got a medical alert bracelet, in the very unlikely or not so nice scenario you can't actually let people know, there's no reason to think that you're going to be given that drug. So there's no need for an adrenaline auto-injector. So aspirin desensitization. What we do, and you're going to ask me how come this is actually used, because I've just told you that in patients with NSAID exacerbated respiratory disease, If they take an NSAID, including aspirin, it will trigger asthma, it will trigger nasal symptoms. Yet, if patients are made to tolerate aspirin and then continue to take it daily, they will improve. Their asthma will improve, their nasal polyps will grow a lot less quickly. So it's actually beneficial. And it is completely counterproductive, and we don't exactly know why, but it works. So, what we do is we give patients increasing doses of aspirin up to a very high dose of 600 milligrams. Just to give you an idea, the dose you take for cardiovascular prevention is the 75, the baby aspirin. But for anti-inflammatory or for pain or fever, you generally take 300 milligrams per dose, which you can take 3 times per day, but as a sporadic kind of use. This is something that will need to be taken every single day if it works. So we basically get the patients to take doses. As expected, they will react at some point, generally with low doses from experience. But what we do is we treat those reactions. So we give them the bronchodilators, we give them the nasal decongestants, we may even give them the antihistamines. And when they are back to what they were when we started, we give them the aspirin again. And they don't react to that one anymore, because they've already used everything they had to react, so they will be able to tolerate it. And then we just build on that and just give them more aspirin. And most patients, not all, this textbook is one thing, there's always the exception, but most patients following that first reaction and tolerating the same dose will then swim through it and go up to the 600 milligram without any further problems. If they continue taking these 600 milligram per day, without stopping, they will never react to it again. But if they stop, at some point they will lose tolerance. So this is why the everyday is absolutely critical, because if they forget and miss it, they may lose the tolerance they gained, and next time they take it, they will have a massive asthma attack. Generally, tolerance lasts, it's been reported, between 2 and 5 days. I generally advise patients, if you have to stop for whatever reason or forget for more than 2 days, just don't take it again and come and talk to me, and we'll have to probably desensitize you again. So when do we use this? Because you think it's quite a high dose. It's quite a risky process. So as you can see, there are reactions that can be severe. Patients can, if things go really wrong, or may need to be ventilated, admitted to an intensive care unit if it comes to that. So they are selected very carefully. And so you will see here that in the indications, it's actually aggressive polyps and severe sinusitis, but asthma is not part of the list. If they have severe asthma, we certainly are not going to do that, because it's a recipe for disaster. They will have a very severe reactions, and basically the benefits do not outweigh the risks. So that's not really indicated. However, all of these patients will have asthma if it's well controlled. It rarely ever will be mild, but and their lung function rarely ever will be with, for instance, FEV1. I'm not sure if you're familiar with, but one of the measures we use in many of them will probably be around 60-70%. We can more or less cope with that, so long as it's stable and controlled. So that's one of the sort of the problems we have to deal with. But it's really to control their polyps, because most of these patients, as I said, their polyps just grow back, and they can do it really quickly. In that they have a surgery, and sometimes 6 months down the line, their nose and sinuses are full of polyps again. And they end up, many that I've seen and desensitized, having surgeries every year. And I don't know if you know how polyp surgery is, but any surgery really, it's not the most pleasant experience, and it's not something you want to be having every year. But the flip side of that is having a completely blocked full nose, where you can't breathe properly, you don't have a sense of smell, which is not ideal, sense of taste as well. So there's a number of problems. So obviously we decided, especially in my service, that we had to establish certain criteria to consider this, because otherwise there are risks and benefits I'll cover in a minute, and the benefits wouldn't outweigh, or the risks actually wouldn't be outweighed by the benefits. So they have to have at least had more than 3 polypectomies or surgeries for polyps within the last 10 years. So if the last one was more than 10 years ago, they've obviously been fine for the last 10 years. They don't really need this. They can just continue treating their polyps and their sinuses as they are, generally with the nasal steroid spray and a couple of other things. But if on the other hand they have really been recent, and especially 2 of them have been less than 3 years apart, then they really would benefit from from this kind of procedure. The other indication would be if they have sinusitis where they don't respond to treatment, they need frequent oral steroids to control their sinus problems. Again, oral steroids, as you know, come with a range of side effects. If you have them sporadically once a year, that's fine, but when it starts happening every month, then we run into trouble, so we need to try and avoid that, and that would be a reason to consider it. Obviously, they have to be patients who have problems with NSAIDs, with symptoms as I explained to you. So what does aspirin do? It improves outcomes, a number of them, particularly upper respiratory, so nose and polyps, in more than 3/4 of patients. So it doesn't work for everyone, but a vast majority will respond, so it's worthwhile trying in these groups. And so it's been shown to reduce the number of polysurgeries. So from average, a patient who needs one operation every 3 years will need one every 10 years. So you can see how good that is. So someone who was, even the one that was having it yearly, will at least be 10 years ideally, if not more, without needing another one, which is a massive, massive improvement. So this is one of the main ones, actually. But then it also reduces infections, the doses of nasal steroids, the doses of systemic, which is another big one, reduces the symptoms, which is also what you want, and in some patients, not all, improves the sense of smell. This is because in some of them, the sense of smell has gone quite a while before, and you can't get it back. So basically, your olfactory bulbs, the little things that are on the middle of your nose that allow you to smell things, because of all the polyps and the anatomy has been disrupted so much, they stopped working, and so they can't be revived. But sometimes it's actually one of the most frequent or more the quicker symptom to come back, or let's say outcome to be noticed after aspirin sensitization. If the bulbs are still functional, patients notice that their sense of smell comes back sometimes within a month after completing the sensitization. So that's a very good outcome. But as I said, unfortunately, even though this has been described in the literature, I can't remember any patient of mine saying that all of them, their polyps, their bulbs were gone. It obviously comes with risks. I've already told you about asthma. I was unable to desensitize a patient precisely because of this every time. So as I said, generally react once, and since then it's fine, but there's always exceptions. And in this particular case, this patient was reacting every time I gave him a higher dose with more severe reactions, not just asthma. And we had to accept that this wasn't going to work. We weren't really going to be able to get him to tolerate it. We obviously can't do this if asthma is unstable, as I said. The other problem is you're going to be taking, or these patients are going to be taking a very high dose of aspirin, and that will lead to stomach problems. So gastritis, ulcers, bleeding as well, which can occur in a patient who didn't have any problems stomach-wise before, but even more if already there is a problem of stomach disease. And I'm not saying that these patients should be denied this, but it does increase the risk of complications. And it is reported that almost up to 50% of patients drop out of this aspirin sensitization precisely because of gastric side effects. So they really couldn't tolerate the high doses of aspirin they need to be on. But we can try and prevent that to some extent with these drugs that we call proton pump inhibitors that you will have heard of, to control precisely the acid problems in the stomach, including the gastritis, the ulcers, and reflux. And I do give these to every patient I desensitize precisely for that, but it's not a guarantee that they won't have an ulcer anyway. We keep monitoring it and obviously have to stop if that happens. Bleeding disorders are another sort of relative contraindication. If they are already taking anticoagulants like warfarin, for instance, you don't really want to combine that with aspirin. It's a recipe for disaster, so they are not really a candidate. We do find easy bruising is common, but most patients cope with that and aren't really particularly bothered. But some of them, I had one who actually had to stop and wanted to stop because he just couldn't cope with it. It's covered in bruises, so it's bruises that you don't even know where they came from, and he didn't think it was worth it. But that's sort of one of the least problematic ones, I would say.
What about tranexamic acid?
That would, yes. So combinations with any other anticoagulant are a bit of an issue because, as I said, the dose of aspirin patients generally have to be on daily, and if this is helpful lifelong, are at least 600 milligram a day. So the risk of bleeding is...
So not great with a CPA patient.
I would say if it's only aspirin, because bleeding, or basically the other way around, clotting, and the way our body stops bleeding We are clever, or our body is clever. We were cleverly designed. And there's a number of different ways to tackle bleeding. There's not just one. So if we stop that one, that's it. There's no way to stop it. There's a number of different ways. And aspirin just tackles one of them, but all the other ones are working fine. So this is why, even though you're taking very high doses, not just the baby aspirin I mentioned before, you get, generally the most that you get is easy bruising, but nothing more. But if you combine the aspirin with something that tackles another one and yet another one, then you may run into trouble. So that is the thing. So when you say CPA patients, do they have tranexamic acid?
If they're bleeding, if they've got
right.
Aspergillosis that's causing hemoptysis, then that's, if it's going to work against that, they certainly couldn't be involved in that too.
So salicylate in diet, this is the critical, controversial one, but see if I can tackle it. And this is, so fruit, the Granny Smith, apples, cherries, strawberries, raisins, kiwi, peaches, raspberries mostly. Vegetables, it's mostly asparagus, sweet corn and tomato, so not so bad from that end. Herbs and spices are the big one, really. Pretty much every herb and spice you can think of. Curry particularly, and there's some discussion whether Indian and Asian diets, because they're high in spices and salicylates, could have some beneficial, not problematic effects, but I'll get to that. And then drinks, so coffee and tea. And also fruit juices, some liquors that include fruit or plant-derived compounds. I don't really know actually, but I'll trust Isabel Scapalla, the author of this one. And again, fruit juices and wine and rum as well. So salicylates in diets. There's this interesting paper I found recently saying exactly what I was just mentioning, that the level of salicylate in different foods is highly variable. So you have a paper that says, let's say for instance, raspberry is really high, and then you have a paper that says exactly the opposite. It's not really set in stone. It clearly shows that there's still a lot to be learned in this respect. But that list that I've shown you now is probably what, from compiling everything, what seems to be the most likely explanation. But the other important thing to highlight is how bioavailable they are. That is, what you eat, is it actually going to have an effect on your body? How much of what you eat actually acts on your body and does anything? And again, there's conflicting studies about that. So there's some studies which show that about 40% of what you eat actually is going to have an effect, and that show that it doesn't really do anything. Just to give you an idea, these studies look at how much is excreted in your urine, for instance, and a couple of other levels in bloods as well, and a couple of other things. So we don't really know, but it looks like from compiling everything again, that what you eat, so the salicylic acid, so the not the aspirin but the salicylates, the natural ones, does very markedly. And there's reports that some people ingest only less than a milligram, less than half a milligram really, to 200 milligram a day. So you can see there's a wide range of intake of these substances.
It's somewhat ironically, we had a talk in January on the Mediterranean diet. That's going to be salicylate rich, I would have thought. Nuts, fruits, vegetables.
No, it's mostly, actually, I think the most beneficial benefits of the Mediterranean diet are related to fish intake and olive oil. Yeah. Yes, the seeds as well, the hummus, that kind of thing. So sesame, chickpeas, the legumes. So it's actually not so much the salicylate, I would say. Okay. Yeah. Because those are the main sort of things: the olive oil, the fish, the good omega-6 or 3 really acids, etc. But anyway, so going back to this, so this is mostly actually Asian meals, and the curries that tend to be the ones that are linked to it. But yes, lots of foods, lots of fruits as well. Not so much vegetables, as I said, because it's pretty much asparagus, tomato, and sweet corn. What is important to highlight is that the levels in blood, whatever the intake you have and which foods you eat, generally overall are very low compared to the levels of people who actually take aspirin. Only the 75, it's not even the anti-inflammatory doses, it's just the 75 for cardiovascular prevention. So you don't even reach anywhere near that. Even though you may eat that much, as I said, not all of it will actually work in your body. And so it doesn't even get anywhere near what aspirin does if you take it. So it's really not clear whether the Western diet, as opposed to the Asian diet, where lots of spices are used, can provide sufficient salicylates to have the same effects that aspirin does. So not actually causing risks, which I'm sure is your question, because most people think salicylates will cause problems. I'll cover that in a minute. But actually the opposite. Could they not be helpful? Because as you will remember in the history of aspirin, that's the reason why I showed you, Hippocrates wasn't using aspirin, it didn't exist. He used the willow leaf. So they were using the salicylic acid, the same substance. They were using the salicylates that are in foods. So they clearly have some effect. And it may be that in higher doses they probably will be beneficial and they may have an anti-inflammatory actions, but it doesn't look like the levels we eat in our normal diet will actually be enough to do that. So obviously in these cases that they were used in the ancient times, it was actually willow leaf tea, concentrated salicylates that patients were drinking, which is not exactly what we do. And I'm not intending for you to start doing as well. This is one example of the content of salicylates in different foods, and you can see really all very small. I hope you can see. It's the biggest I could get it. So let's see if we can single out, for instance, nectarines, so peaches nectarines, much, much higher, 3.29 milligram per kilogram of foods, compared to, for instance, 0.5 for the red wine. But then look at the herbs and spices, much, much more, so 25, 12, 28. But this, as I said, is a little bit which a small proportion will actually be active, so in the end, it doesn't really do much. So this goes to show that it probably doesn't have the same effects as aspirin, purely because of a dose kind of thing, but it also, by the same token, shouldn't cause any harm, even if you have a problem with aspirin. And that's my last slide, so you'll be pleased to know. So this is what I wanted to say. The salicylates in diet don't inhibit COX. That's one thing. But we do know, because, as I said, they were used from 3000 BC. They have anti-inflammatory properties. How do they do it then? Well, there's recent data, as I said, there's still studies going on about aspirin and salicylic acid, that the salicylic acid inhibits the expression of the COX-2. So this enzyme, it doesn't actually block its activity, it blocks it from actually being produced, which amounts to the same. So we know that this substance does stop the COX-2, which is what we want. It's the inflammatory one that we want to stop. So that's how it has its anti-inflammatory action. The problem is at therapeutic concentrations in a dose-dependent manner, meaning that you need a significantly high amount for that to happen. And you generally don't get that with the ones you eat in diet. So it is unlikely that this effect is achieved by the doses you eat. And following that, there's no effect really for most patients. They don't get their asthma exacerbated when they eat salicylates in diet. So there's this misconception that patients with aspirin hypersensitivity need to avoid salicylates. Many have tried. I'm not sure if you're part of this group. I've seen quite a few come to my clinic and said, it's a terrible diet to go through. It's very unhealthy because you avoid quite a lot of fruits, and I like my tea and coffee, etc. How can you survive without coffee? I don't know. But I didn't get anything out of it. I didn't notice any difference, and I just tell them I'm not surprised, because that's generally what happens. So there is really no evidence that a low salicylate, and I can't say strict avoidance of salicylates, because that's impossible, but a low salicylate diet, there is no evidence that it is beneficial. However, I just put that little note there. They could still cause, there are some patients who genuinely have problems when they eat high foods with high content of salicylate, and they do generally have exacerbation of their asthma, and we can monitor that because we can get them to try this low salicylate diet, monitor their peak flow, monitor their symptoms, and we can find very, very few of them that they will have problems. It may be that they're having more, it may be that they're more sensitive, it may be that it's a completely different mechanism and it's nothing to do with them being having problems with aspirin. And these salicylates are acting as what we call the pseudoallergens, so they're not really allergens, they're just pretending to be like one, just like the sulfites are. And you've all heard, I'm sure, problems with sulfites in wine, in beer, which can cause, in a significant proportion of patients, asthma attacks. They're not allergic as well, even though they're classed by the Food Standards Authority, and in Europe in the 13 list of big allergens that need to be declared in foods along the peanuts, the tree nuts, the shellfish, the fish, etc. They're really not an allergen. That's the only one that isn't. It's the same kind of thing. They're a pseudoallergen, but they can cause asthma attacks. They can also cause rashes and urticaria. And the same with colorings, food additives. There's a whole range of substances that could potentially, but very rarely, cause asthma exacerbations, but they have nothing to do with aspirin, and it may be that salicylates do that in the same way. We don't really know. So what I would say is, generally there's no indication to try a low salicylate diet, but if you actually find that there is a connection, and generally it's easily established because the timing won't be too far off between eating something that you then find is actually high in salicylate and your respiratory symptoms are triggered or made worse, there may be a point in trying this, but in a way supported by a dietitian with proper assessment, so we can say yes, there is a problem or not, and yes, you may benefit from doing this, because you don't really want to be depriving yourself and actually going through a difficult diet that really gives you no benefit. And that's all I had to tell you.
Any questions? I have a question from Professor Denning.
Okay, don't think I can answer that.
The reason he asked me to get someone to have this discussion, which you kindly don't, is that he was under the impression, as you just came down to the end there, that we need to adjust the diet of someone who he thinks has salicylic acid allergy. You're now saying no point in doing that.
Not. Yeah.
So there's no need for a diet sheet.
I don't think so.
Excellent.
I hope I made that clear.
That's what you really
Even
did,
though
yes.
there might be some exceptions,
Yes.
and we've had a couple of
there's
patients being
nothing
referred. No.
And we have had a couple of patients who is given the sheet to and they have improved. But like you say, it could be
A number of different reasons, yeah.
I doubt if you can rule out actual
I guess it's the old story, isn't
anxiety.
it? What works for you.
Yeah.
Absolutely, and this is a completely different discussion, because there's this theory we have. Actually, we've all heard about this: the microbiome, the proteome, etc. We are all very unique, even though we're all very similar, and so obviously each of us will deal with what we're thrown at differently. And so there are some foods when patients say, oh, this doesn't agree with me. It's a very good way of describing it, because that's exactly it. Things need to agree with you. And there may not be as yet a completely scientific explanation for it, but this is probably the reason.
On a more general note, do you find that people who have allergies suffer from more than one allergy? Is that a common thing?
Okay.
So some people are more susceptible.
Yeah.
It's another half hour.
That was one of the questions you had asked earlier. So I need to answer that. We need to specify when we're talking about allergies. So the allergies, generally, you have two sort of main groups, what we call the atopic conditions, which are exactly that. It's a tendency to produce allergy antibodies, like I've shown you, to things that normally don't cause any harm. And in those patients, who are the vast majority, you tend to have what we even call the atopic march, because it's like that. You tend to have a baby who develops eczema, that's the first one. And then they will have a food allergy, generally to milk. And then later on, they will have their hay fever and they will have their asthma. They tend to be related. The food allergies, they can have reactions to milk and later on to peanuts. So these are what we call the atopic patients, and they come with everything. And this is again the beauty of an allergist, because we deal with everything. I'm not selling my food, but that's what it is. So they do come in hand. So if you're talking about food allergies in these patients, yes, they can have more than one to completely unrelated foods, and they will have more than one different allergic condition, because they're all sort of come from the same problem mechanism. Drug allergies are different. So with drug allergies, there generally isn't a connection, and there's some risk in atopic patients or in patients with asthma, because if they have, for instance, more frequent exposure to antibiotics. Drug allergy is a topic for another sort of 2 hours of discussion. But having frequent courses is one risk factor for developing allergies. So patients who have that, if they're atopic and they need to have infections, they could potentially slightly a risk factor, but there isn't really a connection or an association. So I hope that answers your question. This is also why the other types of allergies sort of run in families. So you tend to have, you could be the only one with hay fever and asthma in your family, but generally, if you have a parent or two even, or siblings who have an allergy, not to a drug, but rhinitis, asthma, or a food allergy, or eczema, you're much more likely than everybody else to develop one of those. Not necessarily the same, but to develop one of those. But that doesn't happen with drugs. So it's slightly different. Venom allergy is also sort of slightly different, but there's a slightly higher risk with atopy, but it's not part of the atopic march. The atopic march are these conditions that I've mentioned. I hope that makes sense.
In a cohort of patients that are constantly have to take itraconazole,
yes,
voriconazole
that
every
increases
single day,
the risk.
There's a small number who have been on Facebook in the last week saying they've become allergic, or they describe it as an allergic response, they can no longer take it, and subsequently they've counted 2 or 3 different allergies to food. So you've got 2 questions there.
I see.
If you've got long exposure to a specific drug, can you become allergic to that drug?
So again, starting with the first one, which is the antifungals in the food. No collection whatsoever.
Yeah.
Coincidences,
Other than
they
that,
do
they
happen.
may be atopy.
They may be atopic, but again, if you're atopic, you're not more likely to be drug allergic.
Right.
So again, I wouldn't say that they have anything to do with each other. And whether they do have a food allergy or not, that's another thing, because unfortunately there's lots of things that are perceived by patients and sometimes fueled by other health professionals, non-allergists, that are seen as drug allergies. The example of the patients with chronic urticaria, they all come with the label of food allergy to a question mark, but they still do. Most of them are avoiding. I have to say, and I'm not exaggerating, I've seen a couple of patients who were having little more than water to eat, because every time they had a rash, and if it was happening a lot, it must have been the chicken I ate last night, I'll cut chicken out. It must have been the milk, I'll cut the milk out. No, it must have been the fish. And by the end of it, and some of them actually realize, actually this doesn't make sense, can't be the food. But many will continue and will start eliminating more and more and more without realizing that it has nothing to do. So when you say they developed food allergies, I'm not quite sure without talking to them. There is also, and this is beyond the talk or the topic of this talk, but there's a lot in the internet and on the media, unfortunately, that misconceives patients and gives wrong information. There's lots of tests that are so-called to diagnose allergies that are certainly not appropriate. They've not been recommended by NICE. I'm sure you've all heard of NICE. NICE says specifically these tests are not valuable, they should not be used. I can understand why some patients resort to that, because their GPs don't know where there are allergies. There aren't many of us around, unfortunately. They don't have anywhere to go. They're struggling. They need to find a solution. This looks like the solution. They go and they have this test where they have a hair tested or something with the electric wire, or there's a number of different very weird and wonderful things that can be done. And then they're told to avoid a number of things in diet. Generally the staple foods, I have to say, and I find it really upsetting because it just makes the problem worse. They now have the problem, which doesn't improve, but they are avoiding foods unnecessarily. So that's just a digression about food allergy and whether it is or not. Taking itraconazole daily is actually not so much a risk factor. So the risk is actually frequent or intermittent courses. Daily treatment is almost like desensitization.
Yes.
You don't have so much of a problem. Another example completely different is, you probably all heard or have relatives who are the same. You have pets, you live with your parents, or you have your kids living with you with pets at home. Everybody's fine. They go off to university, come back, they can't be near the pets. So whilst they were exposed, they will have been the atopic type, but whilst they were exposed regularly every day, they weren't really reacting. They moved away and then became exposed, and they are exposed intermittently every time they visit during school holidays, university holidays, and they have problems. So, yes?
I was going to say, I have a lot of, unfortunately I've watched the category, but I have a lot of food intolerances, and this has gone on for quite a number of years. But I was always with Professor Orwell.
Yes.
He was the one who, the gastroenterologist, looked after me. But although I never said there were allergies, but just occasionally an allergy has popped up, and then all of a sudden I became allergic to fish.
Okay.
So it just came out of nowhere.
And that can happen.
And they just said to me not to try eating it again. And then more recently, my biggest problem is that it's not so much with the antifungals drugs, it's the antibiotics that cause me the biggest problem. Because sometimes I have a reaction, I take them, then I have a reaction to them, and then I have a mild reaction. And then this most recent one, I had a full-blown allergic reaction to it within half an hour of taking it, and that, I was told I shouldn't take it again because it was so bad. So because with the food, I often try to reintroduce things, but it's not so much the top things; it's the pain and I won't go as far as this now, but I have been admitted to A&E in the very early days, thinking that they thought I had appendicitis twice, and quite often they thought I've had gallstones, and it's not gallstones. And I just say, no, once I get rid of my body gets away from whatever it is that I've eaten that's caused.
You'll be fine.
Because quite often there's stuff that's hidden in food. Like there was, we ate out and I had bacon and chicken filling in a jacket potato. Thought I was fine with that. But I was really, really ill later, and when I phoned up and found out what was on the list, there was actually milk in the chicken, and I can't tolerate dairy products anymore. But I've always tried to reintroduce them, but the symptoms pain gets worse and worse.
So a number of things to answer to that. Can you develop allergies later on or after taking antibiotics or eating foods for a number of years? Yes. Why? We don't know. So yes, you can. And many patients, particularly with drug allergies, because actually they're much more common in adults than they are in kids, to be honest. Unlike the other atopic conditions, which start from sometimes 3 months of old age, the eczema appears and then they just continue having allergic problems. So that's one thing. If you had problems with antibiotic and they were suggestive of an allergic reaction, you should be seen by, not necessarily me, but in an allergy clinic, because we should try and identify that. We should give you information, this kind of card, so you are prepared to avoid accidental exposures, and we should try and identify or broaden the choices as much as possible. You perhaps have lots of other choices and this isn't an issue now, but in many patients you start adding them up, because with ones you have side effects, with the other ones you have an allergy, and suddenly your options just start reducing drastically. So it's really important to try and assess that and try and give you as many as possible, and we can certainly do that. With regards to the pain, allergies don't cause pain. You have nausea and vomiting as part of an allergic reaction, generally not in isolation,
Yes.
but pain, distension, wind, they're not caused by allergy. They could be an intolerance, as you say. It's a very woolly term.
Professor always said that, yeah.
So intolerance, there is a specific type that we know exactly, and it's related precisely to milk, called lactose intolerance. And in that particular case, what happens is lactose is a sugar of the milk, and it needs to be broken down when we digest it. And we have an enzyme, it's again another enzyme, called lactase, which breaks it down. And patients with lactose intolerance don't have this enzyme or don't have enough of it. It could be an acute and temporary problem. Generally, most people have gastroenteritis. This enzyme is in the lining of your gut, and when you have gastroenteritis, generally the lining is pretty much messed up, put it that way. So you lose most of it, but you then regroup after a while. So shortly after having gastroenteritis, you may have a degree of lactose intolerance because of that, but slowly your body and your gut recover and you go back to normal. But you can have a genetic defect where you don't produce this enzyme, and you will have it from birth and always have a problem. That's very easy to diagnose. The symptoms are very typical. Eat anything with milk, particularly with more higher content of lactose, you will have pain, crampy pain, distension, diarrhea.
That's what happens to me.
There's a breath test that we can do to try and actually diagnose that very easily. That's the only type of intolerance I can think of that we can actually do that way. Everything else is a bit woolly. And again, it's with the lactose. There are some dairy products that have a lot less lactose content than others. So yogurt and cheese sometimes are tolerated, whereas milk is not. But again, it's variable, and it's not something that you can apply. So generally, having lactose-free products solves the problem, because you can still have milk. It's the sugar in the milk. Or you have non-cow's milk, non-mammalian milk. Actually, that's the other thing. Cow's milk and goat's milk, mare's milk, donkey's milk, they're all very similar. If you react to one, you react to all of them. So if you have a problem with allergy to milk, you have to try a non-mammalian milk instead. But with the lactose, it's simply a case of removing the lactose from your cow's milk and you'll be fine. The other problems, yes, we know many patients, I was just saying the microbiome and the foods that agree with you and don't. There are patients, we all have wheat. There's a number of discussions, and this is beyond, again, this talk, but there's a number of discussions on how we change the wild wheat that our ancestors many millions of years ago, well, probably not so much, changed to now sort of tame almost, to make it in sort of fast growing, lots of flour yield kind of plants that we use for our bread and other products. But even though it has been changed, we know that many patients, when they eat bread and meat products, they will have gastrointestinal symptoms. They won't tolerate them very well. It's not an allergy, and we sort of label everything under the intolerance sort of kind of label. The bottom line is, in the end, you work out what works for you, as Chris was saying, and you basically, in these cases, the difference with allergies also, not only the symptoms are completely different because they're only gastrointestinal, but also small amounts very usually are tolerated, or very commonly are tolerated. It's finding out which dose, what is your threshold, and which dose actually above which you have a problem. That tends to be the case. Whereas with allergies, even small amounts will very likely lead to symptoms, possibly not very severe, but they will. So that is the difference. So I think it's a case of having a chat, having a dietitian as well, especially if you're avoiding things, and try and see. But with the drugs, I certainly would get an assessment. You had a question as well, didn't you?
If you've got parents of a baby who's now suffering from eczema, both parents, this is my son, his wife, and now the baby has got really bad eczema, what's the best way to tackle it? They have, trying different creams now and steroid creams, and I think they are going to refer if this doesn't work. But what is the best way to tackle it?
Okay, so two answers there. One is, how can we prevent it, which would be the ideal scenario? And once it's already there, what can we do about it? Which is where you are at the moment, or your grandson is at the moment, or granddaughter?
Yes, my granddaughter. Okay. By the way, I've got asthma, eczema, and I've had it.
So again, runs in families. So preventing. There's been a lot of studies to try and figure out what we can do. But again, going back to it runs in families, it's not a simple genetically determined disease like, for instance, haemophilia, where we know exactly it's a gene in the X chromosome. If the mum has it, any boy will have it, and the girls will not. And we know exactly, if we have the genealogical tree, we know exactly who will have the disease. With asthma, with allergies really, atopy, not the drug allergies, and I can mention that as well to confuse you more, but with atopy, what we know is that it's hundreds of genes interacting with each other, interacting with the environment. So, bottom line is, we have no idea. We have no way of identifying a single culprit. There is never going to be anything that we can do from a genetic perspective, because everybody will be different. And when I say interacting with the environment, I mean, for example, very nice studies done in identical twins. So they have exactly the same genetic framework, but if they've been separated, sadly, for whatever reason, and they grow in different environments, we have found that some of them develop allergies and some don't, because the environment does contribute to it. And that means what you're exposed to from a young age, from a pollen point of view, from an allergen point of view, from a food point of view. And that leads to where we've been looking at the most in terms of prevention, which is food and introduction of food in kids that are at high risk of developing atopy. So kids from an atopic family who have at least one parent. In your case, it's grandmother, parents, and so everyone. So definitely there's a strong genetic pull in your family that obviously led to that outcome. How can we prevent kids from developing allergies? Conflicting results, but the bottom line in what we've certainly confirmed is helpful, is not going to be a fail-proof solution. In fact, there isn't one, is exclusive breastfeeding for the first 4 months. So delay, not 6, 4 is enough. 6 are recommended by the World Health Organization. Yeah, and it's fine to, so breastfeed as much as you like, but don't introduce any solid foods before 4 months. After that is fine. There was, until very recently, the theory that actually delaying introduction of allergenic foods was beneficial. And the biggest example for that is peanuts. You probably are all aware that until not long ago, we recommended to every pregnant woman not to eat nuts, and breastfeeding women not to eat nuts to reduce the risk of nut allergy in their kids. We've now withdrawn that advice, and in fact, not long ago, a study done in the UK called the LEAP study has shown the exact opposite, that introducing peanuts early may actually be beneficial. In fact, it is beneficial, and this is an interesting one because it was a colleague that lives in London that was talking to an Israeli counterpart and saying, we have so much peanut allergy in the UK, why is that? And he was saying, we don't. We in Israel, we don't really see much of it. And they started thinking, well, genetically we're not that different, because really we've all sort of come from the same sort of genetic pool. It can't just be that. And they realized that in the Middle East, as you know, they use nuts a lot. They introduce peanuts and seeds. So they have even these bamba, that's what they use in this study, these baba snacks, which are peanut flour-based snack that melts in the mouth. So it's safe for young kids because of the obviously choking problem. And these babies eat and live on these snacks from 2-3 months of age sometimes. And overall, there is very little, if any, peanut allergy in Israel. So they thought, could it be that? Shall we try it? And they did. And they found that it was indeed the case. So they introduced, I think they started from 4 months because, as I said, exclusive breastfeeding until 4 is one of the factors that has been shown to reduce the risk of allergies. But then actually introducing these allergenic foods earlier rather than later may actually be the way around it. But we're still trying to work out how early, how much, how. And even though it has been shown for peanuts, there have been studies done with egg, not exactly so promising, and in fact lots of kids had severe reactions at home. So it's still a work in progress, and we don't have an answer apart from exclusive breastfeeding for 4 months. That's prevention. When you already have the problem, you need to be seen either by, well, GPs can manage it when it's mild, but if it is severe, you need a pediatricologist or a dermatologist, basically. Topical emollients are sometimes seen by parents and patients as not really important. They are crucial. I wish I had slides for all this, but if you see your skin as bricks, what happens in eczema is you lose the mortar that keeps them together in a simplistic way, and that's why the skin scales. There's a lot more going on. There's inflammation, it's itchy, it's red, it's unpleasant, but putting the mortar back is one of the crucial steps to help, and that's what the emollients do. And they have to be the thick, greasy ones, not the light, watery creams that don't really do much. So the ointments are the main thing. Not quite, but things like, so any ointment, I don't think E45 comes in it, it comes in a cream, I don't remember the ointment. But yes, along those lines. So it has to be simple but very moisturizing things that have mostly paraffin, really. So there's a number of examples available. I don't want to name any brands, not to, but yes, there's...
So you're not on the BBC,
okay. Diprobase, hydromol, epiderm. There's a number that come as an ointment that have very little added in terms of other substances that could potentially irritate the skin. So again, this is another reason why ointments are preferable, because they're generally much simpler. If you read the composition of most of these ointments, you will see white soft paraffin, liquid paraffin, end of. If you go for a cream, I could stay here for another hour just going through the list. So they are much better, and that is one of the main things. Use as much, it's a pain, but if you get the little kids used to being rubbed early, they actually accept it, and it makes a big difference. And sometimes that's all you need to control the mildish forms. When it becomes a little bit more troublesome, topical steroids will be the next step. Depending on the age, there's a different group of drugs that we call, that are sort of steroid sparing, called the calcineurin inhibitors. Alidel and Protopic are the two brands available, but they're not available for young kids. But they could be used depending on the age. And then there are, if it's widespread and severe, you may even have to take oral medication, UV treatments, there's a number of things. So there's a lot that can be done to help. But I can't emphasize enough how important it is to moisturize, just simply moisturize. And also simple measures, avoiding irritating factors, so heat, perspiration, baths with very hot water, so they can soak in the bath. And in fact, it's a very good thing as well to use bath substitutes that are emollient. So these same brands will do. Cetraben is another one. In fact, I use that for my little one who has a bit of eczema, and so just putting them in the water with that, rather than using the standard shower gels you would have, which dry the skin a lot, that is very helpful as well. And then obviously treating the acute inflamed areas will need more than that. So you basically need to be seen, or if it's struggling, you need to get your little one to be seen by a specialist. But the GP should be able to manage it to begin with. And if you find that it's not really helping, then you need to ask to be referred. Thank you.
Any more questions?
All my allergies are cured by having a cup of tea.
It's the salicylate.
He did not offer one.
Is it?
There's one question I have to ask, because I've asked it so many times, and it's quite simple. Is it okay for people who have an aspergillosis to
Yes.
eat foods related to fungi, such as yeasts, mushrooms, that type of thing?
I would think so.
Black pepper has a lot of aspergillus in it.
So aspergillosis is
Allergic aspergillosis, let's say.
yes. They don't really have an immediate allergy, so this is sort of a delayed type of reaction. Exposure to the molds will be a problem. Generally, I would say that eating them, it's not something I've come across very much, to be honest, but I would say that eating them is probably not ideal. But unless they've identified problems or they feel that they feel worse with them, I have to say, when you say mold related, so one thing is, when you leave your cup of coffee for 3 days and you see those floating things, you really shouldn't have that. And that generally is aspergillus. It's not really good, even if you don't have aspergillosis. And moldy foods. So the only moldy foods that you can eat are the moldy cheeses, which we know are safe. And they tend to have a different type of mold. It tends to be penicillium, which is again not related to penicillin.
There's a lot of cross-reactivity antigenically.
And do you know of any patients who actually find problems with moldy cheeses?
People who claim that they do, but
Okay.
I have no idea.
It's not something I've come across, to be honest. And certainly mushrooms are slightly different, even though they're salt part
Yeasts
of
are
the...
even more different.
Yes,
But
yeah.
that could be a glucan type.
Could be.
Glucan, yeast, glucan, wheat, glucan, what's the difference?
With allergies, it's proteins rather than glucans,
Yeah.
again, generally.
Sugars.
There is one exception, recently described to mammalian meats into a sugar, which is alpha-galactose. It's what galactase 1 alpha-galactase or something along those, alpha-gal for short. And it's present, it's basically in every meat, mammalian meat, so we have it as well. But the interesting thing is that patients react to eating meat And even though it's because of allergy antibodies, it tends to happen several hours after eating. So it takes a while sometimes for patients to pick up the connection and for us to identify it as well. But it can lead to anaphylaxis. It's rare, but you basically, if you eat any mammalian meat, so I mean, and I'm saying this because poultry is fine, so chicken, duck, turkey are okay. It's the cow or the beef, the pork, the lamb, mostly venison, all of those will cause symptoms because it's the same sugar, exactly the same, and like the proteins which vary a lot, this sugar is exactly the same across all of them. And interestingly, it seems to be triggered by tick bites. That's another one. So
don't start that off.
No.
Oh, my word.
I'll move on. But that reminds me of the fish as well. Sometimes fish allergies can be a problem, or most of the time when you have a problem with fish, it tends to be the whole range, because the protein that you're allergic in fish, or the main one, is highly conserved across the different types of fish, meaning that if you recognize it in cod, for instance, you're very likely to recognize it in tuna and salmon, etc. However, that is not the case for everyone, and there are patients who only react to the cod, as an example, and tolerate everything else, or react to the cod and similar fish like haddock, pollock, etc., but will be fine with salmon and tuna, for instance, or the other way around. So sometimes there is a point in trying to clarify that, because eating fish, I'm Mediterranean, Portuguese, and fish is one of the big things I like to eat, and there's a number of reasons, and so I always try, if we can try and prevent you from avoiding. Sometimes we can't, and we find that any type of fish is a problem. Tough, but there are cases, and not that few, that you can actually eat more. So again, another reason to be assessed.
Brilliant.
Okay.
I think we should probably stop there.
Okay.
You've equalled the Mediterranean diet talk, and that took some doing. So, yes, absolutely amazing talk. Thank you very much. And I will remain in contact, so if people have got questions and
That's
things,
okay.
I can email Susanna later on. Okay. Time for that cup of tea then. Just a couple of things to close the meeting, two of which are important, but not necessarily this one. You might not be aware that this hospital is changing. UHSM is going to become the Manchester Super Hospital, which is going to take in Central Manchester Trust, eventually North Manchester Trust, and I think there's another one.
Is it then?
May or may not. Well, there's a certain amount of debate whether that's happening. The message here, this is all happening over the net. It's started now, and it will be hopefully completing in about a year. So we will no longer be called University Hospital of South Manchester, I don't think. However, I'll believe that when people stop calling this Wythenshawe Hospital. But
I was going to say, everybody knows it was Wythenshawe.
yeah, doesn't affect you whatsoever. Okay, your service is staying here. I think we're going to become the hospital that provides a number of specialised services, and we will be the people who supplies that for this whole area in half of Manchester or so. Chris probably knows more about it than me. Keeps it nose to the ground.
So if you called an ambulance, would they still take you to your nearest
A&E?
They
Yes.
have the choice to take you to the nearest one that's within their CCG mapping.
But if
So you couldn't say, I need to go to...
I think you could try to say if you've got something
I have
that's
tried.
specialised. Yeah, I think, but
No,
you'll
Chris,
find that some of them just...
Yeah, they'll take you, and what we do say is, we'll take you to there.
And they
if
assess you and they'll
think
send you. That's
they'll
right.
send you
Yeah,
on, probably.
yeah.
So it doesn't depend on what consultant you're
No,
on.
not at all. Definitely not. It's about your postcode and where you fit in the CCG, because it's your GP, not your address. It's your GP's address. So you could have a GP in Chester, but you might live across the border. The money comes from your GP, not from where you live. Yeah.
In practical terms, the bloke who's driving your ambulance is in a completely different service to the one we're in. A&E are completely separate
Well,
from
the charges
us.
will go back to your CCG.
Yes, yeah.
So it's your GP catchment area. So that's why they'll always drag you to the local hospital, because
He
it's
just wants to get you to A&E, essentially. Okay, so that's happening. I think it's supposed to be coming. I think what it is really is behind the scenes is that there's a lot of all the admin support and all the buying and selling and all that is all going to be centralised somewhere, and they're doing it very, very carefully and craftily, so that we're not supposed to notice it happening. All we know is
2 phases.
we ask for things and nothing happens.
There's 2 phases to it. The first part is central Manchester and all that brings, and the second part is should be if it ever happens. And as I say, there's still a debate out on that. North Manchester, and they've got a big ID unit at North Manchester, that they might bring North Manchester over to here, which would make sense, of course. But they have beds and we don't.
So how many hospitals are involved in making this one that you're going to be involved in?
So central Manchester's huge on its own anyway, isn't it? Then it's Trafford General.
Is it Hope? Hope?
No.
North Manchester.
North Manchester's in the second phase, so that won't happen in the first phase.
Yeah.
But more recently there's talk that I'm not sure whether it will happen.
And they're building specialised centres, so if you've got abdominal surgery, you'll go to Stockport.
But the idea is
cardiac, you'll come here,
so that you have one surgical unit, one orthopaedic unit, one,
Remember all the fuss we had about them closing some of the surgical here? That's because it was moving to somewhere else in Manchester, and that was seemingly part of the same.
We have the same problem where I am.
Yeah.
Where they've moved various things.
And the bigger issue is there's no space. No space anywhere.
Graham said abdominal surgery, Stockport, When's all that going to start?
Well, the process has started, but where it actually ends, we're not sure, and that's why it's still in debate.
Surgery here now.
Well, it depends
12 to 18 months, it says there.
Because the smaller surgery, they've probably done here still, and it hasn't moved yet. Stepping Hill won the bid for the super hospital.
Yes.
I'm not quite sure.
Yes, that was almost a separate issue, wasn't it?
Yeah. So, and I think they got the surgical thing, didn't they? So,
Yes, abdominal surgery is what they got.
But I think it's more major surgery that they got than minor surgery. So it's just how it's classed.
Right. However,
But for now, we're still doing surgery here, so it's still happening. It's not gone yet.
You've still got everything in place?
Yeah.
I think
And then there's a space issue, so that's why we did like to.
One trust the whole of West Manchester.
I think that's broadly the idea, but these hospitals will still be where they are. They're not closing any or anything.
Just all under one trust.
It's just about making sure the best use of services and the best use of space and staff, instead of having all these pockets of services in each hospital. Yeah. We'll still do all respiratory. That's one thing that you can be absolutely sure about.
right. I've only got 2 minutes, so I can only talk about a couple of things. I just was saying we're holding weekly meetings on Skype every Thursday at 11. Been pretty successful. We get 8 to 10 of us every week, and we just have a similar to this, but it's online. And I do a little talk, it lasts an hour. So if that's of any interest, and you can find us on Skype, there's you go on the NAC patient's website, and there's instructions there how to get there. It's working very well, very good. Lots of things there to talk about which I haven't got time for. Blah, 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 blah. And all that, blah, 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 blah.
Did you see that thing in the paper last week about bronchiectasis?
What?
Did you see the thing in the paper last week about bronchiectasis?
No.
Was it the little thing? Because that's what I talked to you about, Graham, and I said I'd bring the cutting in. Is it that little device?
And I've forgotten to bring it.
I know, I did the same. I talked to Graham about it. Yeah.
It was about infections that were resistant, and this, they've done a trial somewhere. Is that the one?
Possibly, or have I looked at something different?
It was something to do with the immune. They'd altered something, and anyway, this drug-resistant infection, these two patients that we quoted in the article have improved.
I'm interested in that.
I'll scan it and
so
attach it if I've got your email. If not, I can send it
Got
to
mine,
you.
haven't you? Yeah.
If you are interested in going in the Skype meeting, I won't be there next week. I'm away on doing other stuff that day, unfortunately. So the next meeting is a week on Thursday, the 19th. Likewise, to end on a high note, Friday, the 9th of June is the date for the next one of these meetings. Neither Chris or I are going to be here. So we've shifted it back a week. It would have been on the 2nd of June. Now it's going to be on the 9th of June. Same place other than that. And I'll be suntan coloured because I'll have just come back from holiday in Scotland.
Yeah, I'm not here that week, Graham.
That's all
Friday
right.
the 9th.
I can do it on my own. It's all right.
Yeah, no, I know, but you put pharmacy speaker and he's with me that week.
Oh, he can't come. He can't come. He's got to come back.
He's with me.
I was going to say, Chris is lining up a pharmacy speaker who she's quite close to.
Yeah, it's my son. We're on holiday.
to speak on how we transport drugs and all that sort of thing. So that should be.
There's been a question raised
quite
on the
interesting.
storage of a particular drug, so I thought I'd get him to do all of them.
Yeah, so
as you do.
It looks like he's going to be July.
He'll be busy. I mean,
He's
I'll
going to
be
be
coming
July.
back. He'll be still there.
So I've got to get someone for June. So I don't know who's going to talk about on June. I might get to do my bits next
the
month.
fact that you rattled all those topics.
Yeah, all that.
To do that.
Plenty there, isn't there? There's a big discussion group there, actually. We've been asked to do a patient priorities thing for the European Lung Foundation. They want us to come up with things that you want, how you want future treatment, diagnosis, anything to do with your quality of life to go in the future, where we should prioritise for European spending, European priorities. So that's quite a big discussion. I had half a dozen suggestions. One of which is that here at the big ERS conference, the patients have their own bit of the conference and they give talks. And doctors sit there and listen to them, and vice versa. Anyone want to give a talk at a conference?
No, what you always volunteer me.
So that's one volunteer.
You just want cups of tea in different places.
That's just one option for that. That's a patient priority. There's a lot of people in the European Respiratory Society. They have a group of patients who push their own agenda into the doctors, into the clinical side by running their own little bit of the ERS conference, and I've been to that, and it's really good. In Amsterdam, I think it was, and there was one talk from a patient, and you bring other types of speakers in who are involved in patient involvement, and it becomes a whole patient bit of the conference, which we could possibly do at the AAA at some point, or even hold a separate type of conference. That's just my suggestion for one possibility. I'm trying to clarify whether they've asked us to do this prioritising, whether they're actually going to provide us with any resources to carry out any of these projects, but she hasn't answered yet. So it could be that there's a bit of money there. Mainly I wanted more involvement with people with other languages. That's the other thing I was interested in doing. But you've obviously got other priorities, other quality of life issues. This is your opportunity to tell me what they are. But next time, not today, because we have now run out of time. Thank you very much for all coming.
Thank you.
Hope you come back in 5 weeks. Otherwise, I won't be here. And have a safe journey home. I've still got